Wonderful. Well, let's get on with palpitations. So palpitations is such a common presenting feature. And it trips people up all over the place. So this talk is to try and help you with your approach to patients with palpitations. And we've got these 4 customers who are coming through our door over the course of the next 50 minutes or so. So it's going to be, imagine you're on CDU with the most interesting 50 minutes of your career ahead of you. So our patient 1 presents, and she presents with a history of palpitations that are fast, last for long periods of time, have been getting worse in the last few months. And while she's getting the palpitations, she feels weak and pretty rubbish, and she's generally feeling tired and rubbish, even when she's not got the palpitations. She's sweating more than usual, and she's feeling flushed all the time. And she keeps on coming back to tell you that she's having hair loss, and you keep on telling her that you're doing a cardiology placement and she needs to see her GP about her hair loss, and that's making her quite irritable. Other clinical info: no past medical history of note, no medications, no family history. She's a bit tachycardic, slightly high blood pressure, although she's a bit anxious and irritable because you're not listening to her very well. So her blood pressure is a bit high, normal heart sounds. So what do you think the differential diagnosis would be here, and what investigations would you recommend?
Thyroid function test.
Hello, can I hear you? Yes.
Thyroid function test.
Thyroid function test. Very good. So this is the sort of, please write in the chat or unmute and speak. I really don't mind which at all. I'm scanning the chat, so I'll see straight away if you type a comment. So thyroid function tests. I've given you lots of symptoms here that point towards thyroid function tests, and the photo that goes along with this presentation is also a little clue of thyroid eye disease. Great. Somebody else has suggested doing a full blood count because it could be anemia causing fatigue. Absolutely. So I'm showing you a young female patient. Anemia is not uncommon in this sort of cohort of patients. Anemia is common across the board. All sorts of people could get it. So certainly something to look for. Anything else people thinking of? Electrolytes, including magnesium, doing a 24-hour tape. Yes, you could do electrolytes. I'm not sure magnesium would particularly help here, but yes, you could think about doing that. A 24-hour tape to try and capture her palpitations. Depends a little on how frequent the palpitations are. If they're occurring daily, then you've got a good chance that a 24-hour tape will be helpful. Helpful in telling you what's there and what isn't there. So if she's got palpitations and a 24-hour tape is normal at the point in time she's getting palpitations, then you can be reassuring. So a 24-hour tape certainly can be helpful, but if the palpitations are happening every couple of weeks and are terrible for about 6 hours, but are fairly infrequent, then a 24-hour tape won't pick them up very effectively. We might try a loop monitor, which she could wear for a month in that sort of situation. We could do an implantable loop recorder, which will stay in for years, but that would be a bit sledgehammer to crack a nut, certainly at this point. Great. So we're thinking about doing a heart monitor. We're going to do a check for anemia and thyroid function. Can anybody suggest anything else?
If she consumes caffeine or any energy drinks.
Yeah, so could she be drinking huge amounts of caffeine and that be causing the problem? Caffeine's always being blamed as a cause of arrhythmias, and there have been loads of observational studies which have all the flaws observational studies get. Actually, in the last month, there's been a really interesting one where caffeine intake was looked at, but they also looked at genetic sort of sensitivity to caffeine. So they assumed if you were randomized and how sensitive to caffeine you happen to be, that if they looked at patients by how sensitive to caffeine they were rather than by how much caffeine they drunk, that they might see a link to palpitations, and they didn't. Now, maybe if you're sensitive to caffeine, you don't drink any in the first place, so it still could be biased in the way all observational trials are, but certainly if you drink huge amounts of caffeine, then that could be helpful. So Fazia is suggesting we should ask about menstrual history. I think that's a good point. Obviously, maybe she's got an ectopic pregnancy and that she's unwell because of that, and she's not risk of volunteering that because she's either in denial or not aware of the problem. So yeah, that's a good thought. Anything else? Good. Well, I think we've got through a lot of what I wanted to discuss, but there are loads of differentials here, aren't there? And we've not talked about obvious things like pheochromocytoma, which can present with this sort of flushing and palpitations as you get an intermittent surge of adrenaline. The other here, anxiety is obviously a big one. We obviously are looking for pathology. We are assuming pathology, and it's very important not to dismiss symptoms, but that certainly is a possibility here, and might present not dissimilarly from this. Here, there are lots of symptoms to point you towards hypothyroidism, hyperthyroidism. An inappropriate sinus tachycardia can also present like this, and that's along with POTS, postural orthostatic tachycardia syndrome, are fairly poorly understood and they are quite hard to manage. So those are other possibilities. And I think I agree with the recommendations you've given for blood tests. I'd also do a 24-hour urine collection for the query pheochromocytoma. I won't spend the next hour talking about hyper and hypothyroidism, but it's obviously an important condition to consider. Pheochromocytoma, you may be a little less familiar with the main symptoms, and you're probably, some of you are saying, but she wasn't that hypertensive, so it can't be that. But actually, 50% of patients have paroxysmal hypertension when they have a pheochromocytoma. The blood pressure only goes up when they have a pulse of catecholamines going into their system. And 10% are normotensive, so you certainly can't rule it out with the blood pressure. Headache, palpitations, perspiration, pale skin, very similar type features sometimes to hyperthyroidism. So you could easily see how this might be a case of that. Mohammed, you suggested carcinoid syndrome. Carcinoid syndrome is very rare, but yes, it could present in a not dissimilar way from this. So that's certainly something to think about. Carcinoid syndrome causes some very interesting effects on the heart, and it causes tricuspid and pulmonary regurgitation. So an echocardiogram would really help you with that diagnosis. So yes, something to think about. If you'd captured her ECG during the palpitations, you might have seen something like this, probably not in such a young patient. So imagine if this patient was actually 60 and was having hyperthyroidism. They very often present with fast atrial fibrillation. A young patient would be unlikely to have atrial fibrillation with hyperthyroidism. It would be more likely a sinus tachycardia, but obviously be looking out for things like atrial fibrillation. Patients with atrial fibrillation, paroxysmal AF as a cause of their palpitations and fatigue, they would tend to have a sudden onset of the palpitations, and they then tend to fade away relatively gradually. Young patients tend to have very fast atrial fibrillation. It makes them anxious. They get a surge of adrenaline. It goes even faster. So rates of 200 are not uncommon in a young person with AF. Obviously, AF is uncommon in a young person, but when they get it, they go very fast. As you get older, your AV node becomes less conductive, and so you gradually find that older people get slower rates, such that when you're in your 80s and 90s, sometimes you don't need rate control for your atrial fibrillation. It's very variable, of course, what rate control people need. And often patients go too fast in atrial fibrillation and too slow in a normal sinus rhythm. So we sometimes have to put in a pacemaker so that we can control the fast rates without going too slowly. We'll talk about atrial fibrillation in another week in more detail. Great, so that was patient one. We've got through her in just 10 minutes. So we're moving on to patient number 2. So history this time is he has palpitations which are fast and brief. They are sudden in onset and sudden in onset. And he's been getting them for years, but they have got worse recently. He feels a bit lightheaded, pre-syncopal with the palpitations, and he sweats a bit when he gets them. He's otherwise in good health, and he's not got any past medical history of note. He's not on any medications, and examination is unremarkable. What do you think of this chap?
Does he have any family history of any cardiac disease?
Yeah, very, very important question to ask, because if you don't ask, you often don't get told. Patients play little games with themselves. I'm sure you've done the same in the past yourself, although you might not admit to it. You've said, if they don't tell me X, then I won't have to do anything about it. So the patient that smokes might think, if the doctor doesn't specifically tell them not to smoke, that actually it might possibly maybe be okay in their specific situation. So always ask the really important questions. And this gentleman's uncle died suddenly when he was 25 years old. So any other thoughts, any other questions?
Is he taking medications?
Is he taking any, I think I didn't catch the last bit, is he taking any
Oh
medications
no,
or any
yes, I just read no
other
medication.
things?
Yes.
Um, So certainly we should be asking this gentleman specifically, is he taking anything non-prescription? So does he use cocaine or amphetamines? Does he use anything non-prescription at all? Another one to be asking about is anabolic steroids, because anabolic steroids can cause a cardiomyopathy, which might then cause palpitations. So we'd certainly ask him about that. Any other questions? Is there anything key question in the history that we haven't asked about that we should always ask about palpitations?
How long they last? Or
Yeah, we should ask how long they last. These I've written that they are fairly brief, so we could get him to be more specific, and he might say that they last for a few seconds to up to a minute. So they're fairly short. So asking about any associated symptoms and blackouts, I've put here that he has pre-syncope and sweating with them. I've not said that he doesn't black out, but we'd hope that he doesn't, and we've asked him that specifically, and he said no. So any other question? So the other one that is really important about palpitations is, are they worse on exercise? Because if palpitations are worse on exercise, they are far more likely to be pathological. Exercise usually resolves palpitations, particularly ventricular ectopic beats or atrial ectopic beats. Usually they occur when somebody's relaxing, watching TV, or when they're trying to get to sleep in bed at night, or when they're sitting quietly and thinking about their heart. They don't tend to come on when they're busy at work and their mind is on other things. They don't come on with exercise. They tend to be suppressed with exercise. So that's a really important question to ask somebody. So what do we think is the cause of, oh, and he also occasionally uses cocaine. So it's important to ask if cocaine is associated with the palpitations. Possibly here he's harming himself, depending upon is he admitting the amount that he uses. But this probably isn't the main factor in all of this. So what do we think is the cause of his palpitations now, if we move on to a diagnosis? Are you worried about this gentleman? I've had Ashley comment, does he have chest pain? Chest pain in this young individual, maybe he's caused severe premature atheroma by using the cocaine. It's possible. Chest pain associated with palpitations is not a common feature, and it would usually be that you have existing ischemia or narrowings of the coronary arteries, and tachycardia is then placing more demand on the heart and causing the chest pain rather than the other way around. So that's not generally a very helpful symptom, but certainly one to ask. But could this patient have a hypertrophic cardiomyopathy? That's entirely possible with this family history. We're worried here about a serious cause, a potential ventricular cause. So if we do a 12-lead ECG, and the person doing it has helpfully written that he coughed at this moment, I don't think that's really of any relevance to having this. What do we think the CCG shows? Great. So we've had a comment that this shows a VT episode. Can you be any more precise than that? So there are two different types of VT episodes. You can call it either sustained or non-sustained. Does anybody know the definition of sustained and non-sustained? So sustained is over 30 seconds. So that would be longer than an ECG. That would be, actually, this is about 10 seconds of recording. So it would be 3 pages worth of VT. It's if it's 3 or more beats, it's non-sustained VT. So if there were just these 3 beats, that would be non-sustained VT. Here, we might call this a 5-beat salvo of non-sustained VT. So is anybody concerned about that? Oh, somebody's called it polymorphic. Can you see here the morphology changes, but it's because we've changed from V1 to V4. So it's confused you there. Here, if we look in the rhythm strip, we can see it's monomorphic. Somebody suggesting a fusion beat. Well, you need to be in and out of VT to really, you need to be in VT to call it a fusion beat here. This is probably a ventricular ectopy. I agree with you looking at the timing of the P wave and the QRS. Maybe there is some fusion going on there, but I would hesitate to try and call it anything. But that's well spotted. So are we concerned about this? What are you going to do next with this patient? Imagine that you're seeing them in GP surgery and you happen to have access to the ECG, or you're seeing them in an outpatient clinic for something entirely different, like an ingrowing toenail, and they happen to tell you this story and show you get an ECG and see this. What are you going to do?
Um, um, I'd get the cardiologist opinion by calling them that I've got this ECG which shows this. So what should be the next step? Like
Yeah.
whether they want to see the patient looking at the history and everything urgently, or they would just follow the patient up in the clinic in a few weeks' time.
So the cardiology registrar is dealing with a STEMI. You don't know that, but you know they're not answering their bleep. You've got a lot of other patients in your pre-admission clinic who've got real problems that you know how to deal with. What are you going to do? Do you want to send him home and let him come back again?
He needs to be on a cardiac monitor, and we need to do a bedside echo.
Yeah, I think you're absolutely right. He needs to be investigated further, because if you're doing this on a 24-hour ECG, that would make me a bit queasy about the patient. Doing this just when you happen to get an ECG, what on earth is he doing? The other sort of this is about a 10-second run. So what is he doing the other 24 hours of the day, basically? And if you did do a 24-hour tape, you might see this sort of thing. And again, these are not sustained VT, because this isn't 30 seconds. This is probably about 15 seconds. But this is a very, very sort of concerning 24-hour ECG. So you would certainly want this patient in hospital and on a monitor. Does he need an ICD long term? Well, we need to know a lot more about him, and I'm afraid it's probably beyond the remit of the talk today to discuss that, but we can certainly go over that in a future talk. But he certainly needs assessing, and it seems likely that an ICD is going to be considered for him with that family history and that 12-lead ECG. So we might want to try and make a diagnosis as to the cause, and we'd certainly want to do a 12-lead ECG. Now, I've just told you that this was his 12-lead ECG. It's actually a made-up patient anyway. So let's, in the thought process, imagine that actually this was his ECG. What do you think the likely diagnosis is here if it was this ECG that you got when you did the trace? Yeah, there's left ventricular hypertrophy. So there's voltage criteria for left ventricular hypertrophy. I prefer the term voltage criteria because it's so variable on the habitus of the patient, whether or not you see left ventricular hypertrophy or not. But here, there's very definitely voltage criteria. And anything more than that, we've got this deep, widespread T-wave inversion and marked ST depression. So this is LVH and strain on an ECG. And TVI, what does TVI stand for? So what diagnosis that is associated with an T-wave inversion? Thank you, of course. So what diagnosis is associated with this appearance on the ECG? This young patient might have severe hypertension. If he's been using too much cocaine, then that could have caused him to develop severe hypertension and hypertrophy of his ventricle. But what diagnosis is this? This is a classic sort of an ECG for a hypertrophic cardiomyopathy, a familial hypertrophic cardiomyopathy. Good. What about this ECG? Can anybody diagnose this ECG for me? This is maybe a bit harder. Yeah, so there's a sinus tachycardia. It's a borderline sinus tachycardia, but I'll give you that. So the particular concern here is you're looking at the inferior leads, the upsloping. This is, can you see the baselines wandering a bit here? Brugada, very good Imtiaz. So this, can you see? You've suggested Wellens, Emmanuel. No, that this I can see where you're going for with that. But this, can you see the down sloping ST elevation that you can see in V1, 2, and 3? And the best thing to do is actually to put these ECG leads an extra couple of rib spaces up, and you often see it better. It can be intermittently there, can come out when the patient has fever, and this is a Brugada syndrome. And we talk about type 1, which is a diagnostic ECG for the condition with this coved ST segment elevation. There are other types, type 2 and type 3, which is more of this saddleback shape that we just don't really quite know what to make of. So Brugada syndrome could be causing this. Anybody tell me what this shows? So this is actually an ECG from a case report that I wrote a few years back. It unfortunately was the best quality ECG that I had. And this shows long QT syndrome, very good. So here, these odd things, you might say, is that a P wave? Is it profound first degree heart block? Because it's quite hard to see if there are P waves on this ECG, but this is a sort of a fractionation of the T wave with what is this, sort of a U wave, or quite what it is, but it's profoundly abnormal appearance of the T wave, which you often see with very long QT interval. And so you can see this is way too long. If it's over 50% of the RR interval, you should start to flag concerns. And here you can see it's more than at least 2/3 of the RR interval. So this is very long. And when you see these abnormal T waves, which are inverted inappropriately over here and split over here, this sort of a patient is at very high risk of arrhythmias, and this was a patient who came in with recurrent VT. So that's long QT syndrome. And one more very quickly for the gold star, if anybody can tell me what this shows. So inferiorly, you can see some T-wave inversion, but that's not what I'm particularly after. What I want you to tell me is, yes, in V1 and V2, we can see an epsilon wave. So that's that little bump there. at the end of the
RS,
QRS. And that's, sorry, go ahead.
RS, RS, WP.
I'm sorry, I can't quite hear because of the background noise. ARVC, very good. Emma, were you trying to say that, Harsha?
I was actually about to say WPW.
Ah, okay. No, good thought, good thought. But no, ARVC, arrhythmogenic right ventricular cardiomyopathy. So that's a rare condition which can cause sudden cardiac death. Excellent. So moving on, patient 3. Now, this chap is presenting to you with palpitations, and he says his heart keeps on stopping and feels a thump as it restarts. And he's always, thank goodness, it thumps and restarts because he thinks it's going to stop permanently every time it happens. And it jumps and somersaults in his chest as it does this, and he feels lightheaded and breathless and generally awful while it's happening. They often come on in clusters. He has good days and bad days and good weeks and bad weeks, and he tends to get them while he's watching TV. He's not got any past medical history of note, doesn't take any medications, and he's a non-smoker, no family history, and examination is unremarkable. So any other questions you want to ask him? Any thoughts as to what's going on? So is there a key question that we haven't asked this patient that we should always be asking patients complaining of palpitations? So it's the same one before with the second case. Are they present on exertion? Does exertion exacerbate them? Ah, excellent, Pfizer. You must have been typing that before. I assume that says exertion before I said it. So excellent. It's really useful because there are lots of features here that point us towards ventricular ectopy. And the fact that they are not present with exercise, but they do come on when he's relaxing and he's maybe got a bit of quiet time and can be a bit more tuned into his heart, helps point us towards the diagnosis. So really important to remember to ask that one. Are there any other particular questions you would ask this gentleman? So anything else that brings on palpitations, ventricular ectopy, commonly causes worsening of palpitations?
Alcohol consumption.
Yeah, excellent. So we've just been through a lockdown, although we're at the other side, and hopefully we'll never see lockdown again. But patients have really suffered with their health during lockdown. Lots of them have drunk more alcohol. Lots of people have put on weight. I think about 40% of the adult population has gained weight during lockdown, and the average amount weight gained is half a stone. So it's a huge public health disaster that has come from lockdown. And alcohol will exacerbate palpitations. It will also tend to cause hypertension, which it's not doing here, but that tends to happen longer term rather than in a young person in the short term. And it can cause a cardiomyopathy, so it can be bad in lots of different ways for the heart, let alone all the other body systems and the weight gain that you tend to get with alcohol consumption. So important question to ask. And we think that these are likely from this description to be ventricular ectopy. It's a classic description for it. And it's one of the most common types of presentation that you get with palpitations. I see lots of patients in clinic who've got palpitations, and it turns out to be these when you go into the nitty-gritty of the description. So how would you proceed with this gentleman? What would you do next? Yeah, an ECG. I mean, we could think about doing blood tests, but they're not really going to be particularly helpful in this gentleman. If he was in hospital, then I'd be duty bound to. I'd check things like thyroid function again. In anyone with palpitations, I'd check thyroid function. But an ECG to see that heart structure and heart rhythm and heart appears to be normal on 12-lead ECG. If you happen to capture a palpitation, if he's getting them all the time, that might be useful because you might make the diagnosis just then and there from the 12-lead ECG. But you're likely to need to do a longer period of monitoring. And it's important, very good, Chaz, it's important to consider what the frequency of the ventricular ectopy is, because here, can you see we've got patient event, we've got 2 ventricular ectopics, so not non-sustained VT, just ventricular ectopy, and you could call this a couplet. And this explains things. We can reassure the patient. It probably doesn't need anything doing about it other than reassurance. If we really need to, we could give some beta blockers to suppress it, but we would try and persuade the patient not to. Often reassurance is all that's required. It's a little bit concerning here that we've got 2 close together rather than a single ventricular ectopic. I might want to do an echocardiogram just to confirm structure and function is normal in this patient, but that isn't anything beyond that I would do without any other symptoms. Why do you get symptoms? Well, the thing is that these ectopic beats involve very inefficient contraction of the ventricle typically, and so effectively it doesn't do anything for these 2 ventricular ectopics. And instead of having this amount of time to fill, it's got more than, well, double the time to fill. And Starling's law of the heart, heart contracts harder if it fills more, so you get a thump as the heart pumps out all this blood that it's filled up with, and that's the somersault or the thump in their chest. And they notice the pause. They don't tend to notice the actual ventricular ectopics themselves. If patients are having these very frequently, and I would say over 15% of their beats are ventricular ectopics, then it starts to get into the realms that the ventricular ectopy could be causing a cardiomyopathy. And if they're over 25%, that risk increases. I've seen patients as high as 50% who are completely asymptomatic, and you can have just a few and be aware of them and be very symptomatic. So doing the heart monitor to assess the burden can be useful. And if it's very frequent, then we would want to suppress them with medications or even an ablation in order to prevent them causing harm in the long run. But not typically a case in your average patient. I wouldn't necessarily do a 24-hour tape in all patients if we've got clear-cut symptoms. So investigations, I might, as I say, I might try and do nothing other than think about a 12-lead ECG, a 24-hour ECG, and echocardiogram are options. And as I say, if we want to suppress these, beta blockers would be the first line drug. Moving on to patient 4. We're doing very well. We've taken about 10 minutes a case so far. So patient 4, the history this time is of palpitations. And this time they are fast, they last for a few minutes, they come on suddenly, and they stop suddenly. They're relieved by coughing, and during the palpitations she feels exhausted. She's otherwise well, and there is no other past medical history of note or medications or family history, and examination is unremarkable. So what do you think the likely diagnosis is here? Pfizer, you said the previous patient we should advise him to cut down his alcohol. Thank you. That's absolutely right. We should definitely remember to do that. So coming on to this case, yes, Emmanuel, very good. So some form of supraventricular tachycardia with a response to a Valsalva maneuver. So the cough coughing is a bit like a Valsalva maneuver that patients may find themselves helps to suppress them. It's surprising the effect that coughing has on the heart. When I'm putting in a pacemaker in somebody with complete heart block, sometimes as I'm doing it and causing a bit of ectopy, they suddenly have a long pause and their heart effectively stops. And if I ask them to cough before they pass out, then that will trigger the heart to beat. And so it will keep them going and they'll be much more comfortable and I can get my lead in. If I'm seriously concerned about that kind of a thing, I would put in a temporary pacemaker lead or externally pace. But it's worth bearing in mind if you ever have somebody in complete heart block on you're monitoring them and you see their heart pause, just ask them to cough, and that often will keep things ticking along while you do something else urgent about them. So yes, this is sort of like a Valsalva maneuver. This is pointing us towards some form of supraventricular tachycardia. Now, exercise brings on a supraventricular tachycardia. So what can we be more specific what we mean by supraventricular tachycardia? So a supraventricular tachycardia just means a fast heart rate that comes from the top of the heart. So we could have a sinus tachycardia, we could have atrial fibrillation, but also we could have an AV-NRT or AVRT. Very good, those are what I'm looking for. So this could be a Wolff-Parkinson-White type picture, with this being an atrioventricular re-entry tachycardia, or it could be an AV nodal re-entry tachycardia. And I don't know if I've got slides on that here. I'll talk about those in more detail another time. But imagine this was her ECG. What are you looking for on that to help guide you? What do you think this shows? So somebody's suggesting flutter. Thanks, Emmanuel. If the rate is about 150, then you should be thinking atrial flutter. Here you can see the rate's a little under or over 150. So it makes it less likely to be, because flutter waves tend to go round and around the atrium at a rate of 300, and then every other flutter wave is conducted. So you'd have to, in this, which has got a rate of probably about 160, you'd need the flutter rate to be 320. It could be that, but it's unusual. So it's unlikely to be a flutter. The other thing you're looking for is a sawtooth pattern, and you want something 300 times a minute. And so we've got something 160 times a minute, which is the T wave, but we don't have anything else. So this isn't a flutter. Emma's suggesting an AV NRT. So what you're looking at here, the description I'm after, is a narrow complex tachycardia. And I want you to agree with me that this is regular. And so we're not dealing with atrial fibrillation, and that leaves us with flutter. We've said the rate isn't really right. We can't see a sawtooth. And so that leaves us with either an AV-NRT or an AVRT. We can't really tell the difference. Now, if we look carefully, sometimes we can see retrograde P waves, and those will point us towards what is causing, if this is an AVRT or an AVNRT, but it's here we don't see anything like that. Great, I've got some slides that help me explain what these two different conditions are. So they sound very similar, but they're actually relatively, they're not a million miles apart, but they are relatively different things. So these situations both respond to adenosine. So yes, it would be a way of identifying that it was an AVNRT or an AVRT. It wouldn't tell us which. So if we stick with the nodal reentry tachycardia, the idea is that in your AV node, you have two pathways, a fast one and a slow one. And in a normal situation, the fast one gets to its destination first, and so by the time the slow one's trundled round, this has already been excited by the electricity. It's going to be refractory, and the slow pathway never gets to do anything. Poor slow pathway. And so in normal rhythm, you get an atrial signal, whips round to the ventricle, and you get normal sinus rhythm and normal PR interval. Now, you have to have a very specific physiology in your AV node. If you don't have a slow pathway, if you've only got a fast one, you can't have an AV nodal reentry tachycardia. And you need one other property, which is that the fast pathway is a bit like a hare. Remember the tortoise and the hare story? The fast pathway whips round and then it needs to get its breath back. Whereas the slow pathway is our tortoise, which never needs to have a sleep, and it might get there more slowly, but it will slowly trundle on, and it will always be ready to trundle on. And about a quarter of people have this type of AV node. Not all of them by any means end up with AVNRTs, so it's very helpful to actually, when we're burning away the pathway that we don't want to be there, it's very helpful to be able to put them into the AVNRT to know we're burning the right thing, not risking complete heart block in a young person for no reason. So with this very specific type of physiology, if you get a premature atrial beat, so we all, obviously get atrial ectopics all the time. Everybody gets them from time to time. But imagine that comes a bit early, and our fast pathway is in having its sleep. It's not able to conduct this because it's not finished recovering. It's still refractory. But our slow pathway is always good to go. So the atrial signal gets to stimulate the slow pathway, and hooray, the slow pathway finally gets to the ventricle and finally gets to stimulate the ventricle to contract. But during this slow trundling round that the slow pathway has done, the fast pathway has had its nap and is ready to go. And heart electrical wiring will conduct in both directions very often, just like normal electrical wires will. And so the fast pathway is ready to zip back round to the atrium, stimulate an atrial contraction, but also stimulate again the slow pathway, which is always good to go, which then trundles round and stimulates the fast pathway again. And so you get this re-entrant tachycardia, which goes round and round and round. So that's an AV nodal re-entry tachycardia. An atrioventricular re-entry tachycardia, on the other hand, involves an accessory pathway. So the idea is that normally you can't conduct except from the atrium to the ventricle, except through the AV node, but you might have a channel that actually allows the conduction through, and that can be anywhere along between the atrium and the ventricle, and the location of that affects the appearance of the ECG. And if we're trying to burn this in the lab, we need to do detective work to work out where the accessory pathway is. Now, these won't necessarily always conduct. They might do it intermittently. They might only conduct backwards, but they can be capable of allowing the signal through in both directions. And what happens here is you get the signal going down through the AV node, and then it goes back up through the accessory pathway to stimulate the atrium, and then it can go through the atrium back to the AV node and go round and round and round in a circle again. So this kind of pathology can lead to a narrow complex tachycardia like we just saw on this ECG, and you can't tell them apart necessarily. You may get a clue, and it's really useful to give adenosine to these patients and to record the ECG while you do it. Can anybody tell me what this ECG shows? So in the interests of time, I'm sure everybody's rushing to type that there is a delta wave. Can you see here? This is the P wave, and the delta wave occurs very, very early. Look how short that PR interval is. And you can see it quite clearly in these lateral leads. So you're looking at a delta wave, which shouldn't be present. And sometimes it's really obvious, sometimes it's relatively subtle. What about this ECG? What does this show? Torsade, that's what everybody guesses, actually. Good thought. It's looks a bit odd. It's not really corkscrewing around. If you look at this, most of these morphologies are pretty consistent. You get the odd beat forming within it and the beats which look a bit different, but it's not corkscrewing around a point. It's not dancing around a point. Torsade meaning dance. So we've been talking about Wolff-Parkinson-White, and the big worry with somebody with Wolff-Parkinson-White is that accessory pathway doesn't follow the normal rules of the AV node. The AV node will go very happily at a rate of 150. It'll go in a young person at a rate of maybe 200, maybe even 260, but it won't go at rates of 300, 400. And if you expose the ventricle to those very fast rates that you get in atrial fibrillation, you can put a patient into ventricular fibrillation very easily. So this is an example of pre-excited atrial fibrillation. This patient has an accessory pathway. Look how slurred the onset of the QRS is in the lateral leads. And so this patient has got into AF and is conducting rapidly through his accessory pathway. This is pre-excited AF. Really important to diagnose it, because if you miss this or mistreat this, then it's bad news. Do you know how to treat this? So if you give anything that slows conduction through the AV node, you will not necessarily slow conduction through the accessory pathway, so you can actually speed these patients up. So if you're thinking of giving them verapamil, which is a classic no-no, or a beta blocker, or digoxin, all of these are bad news in these patients. What you want to do is give them either flecainide or electricity, and electricity is the one to remember. That you won't go wrong with electricity. So I hope we've been able to go through how you assess patients with palpitations, the questions that you ask, the other symptoms that you go for, and then things like the past medical history and family history and other associated questions that we ask. I think we're running out of time, so I won't spend a lot of time going over all of this, but remember the red flags, and that is, are the symptoms exertional or are they exacerbated by exertion? Does the patient have syncope? Do they have a family history of sudden cardiac death or other concerning pathology? Do they have structural heart disease? That is a big concern in a patient with palpitations. And do they have an abnormal 12-lead ECG? So those are your red flags. That's very, very important for you to remember. And if you're asking questions, the offset is quite useful, because patients often feel their palpitations come on suddenly, but generally they say they go off gradually. If they're due to anxiety, if they're fast atrial fibrillation, they can sometimes go offset gradually. If they're an AV, as an AVNRT or AVRT, they tend to go off suddenly, and patient knows exactly when they finish. Bear in mind, palpitations are difficult to describe, and patients often struggle with the description. There are lots of different causes. There's sinus rhythm, sinus tachycardia, which has got many possibilities. Then there are ventricular and atrial premature beats. There's atrial fibrillation, atrial flutter, atrial tachycardia. The AVNRT, AVRT we've discussed dust, and most concerningly, the ventricular tachycardias. We would think about doing a 12-lead ECG, and we need to be selective about who we investigate further because palpitations are such a common complaint. And if patients give clear-cut symptoms of ventricular ectopy and they don't have any other concerning features, I wouldn't do anything further. But we can do all sorts of other tests if we need to. So that's all for this week. Thank you very much for listening.